When you're dealing with a population who has lost the function of one arm or significantly reduced, in this trial, we used pretty much lost the function of that arm, but even significantly reduced, and you have to rely on the other arm, then that arm has to be very good at manipulation in order for you to carry out your daily tasks. My name is Robert Sainburg, Bob, and my title is Professor of Kinesiology and Neurology at Penn State. And if you have a very severe stroke, you end up with a very stiff arm with the inability to open or close your hand. And so that arm becomes effectively a non-manipulator. You just can't use it effectively. You might be able to move it a bit to help get your shirt on, but you can't pick stuff up and release it. The reason that you lose that function is because the primary and motor and sensory regions, the things that project ultimately down to your arm or from your arm, are contralateral. But what we found from our research over the past few decades is that in other areas of the brain, both sides of the brain contribute to each arm, but they contribute different things. And what we found was the good arm, hand, that's on the same side of the body as your brain lesion, so by old standards shouldn't be affected, had significant deficits in coordination and control. Now, these were often clinically kind of pushed aside. Patients would say, it's really hard to do stuff with this arm. And the neurologist or the therapist would say, yeah, you have postural problems and all that, but really wouldn't see that as an arm that has deficits. And this is a real problem. If you have no movement of one arm, just think about it. You don't use one arm effectively. I tie one of your arms up. I don't care which one, dominant, non-dominant. You'd probably prefer non-dominant. But now you have to go through your day with one arm. You have to put your shirt on, you have to put your clothes on, you have to go in the shower, you have to feed yourself, and you're doing that with one arm, which means that arm kind of has to be a super controller. We made a game. It was like an air hockey game where you had to hit something and everything, you had to predict where the puck would go. And in the other game, you had to do rapid tracing where you had to keep correcting for spatial errors. And we thought these things recruited the mechanisms in the brain, in the side of the brain that had been damaged. And so we tried to remediate those. And then we followed it up with real-world training, which was intense dexterity training, doing a whole bunch of varied manipulation. Very significant improvement right after we finished therapy, and that was sustained throughout 6 months. It's pretty amazing. And for a lot of these patients, it was a little longer because COVID intervened. So we had some people before COVID. We couldn't get them exactly 6 months, but it was really surprising to us. And the biggest surprise was how plastic the system was. Once we hit it with our science-informed intervention, this arm that was resistant to improving, even though they were forced to use it every day, improved significantly. We did have people tell us that now they don't need as much help with their daily activities. There was one couple in the pilot study to this that we asked them the question, what can you do now that you couldn't do before? And the partner that had the stroke, looked like he was thinking about it. And then his significant other, her shoulders went down and she said, I don't have to go to the bathroom. I don't have to go in the bathroom with him in the morning. And so this might not show up on a test, but this is really significant. And so if even a proportion of our patients, we got those kind of changes, it's a big deal, I think. I really think having an experiential background in rehabilitation therapy, you have to get the information into the hands and minds of the therapists. Therapists don't want to be given a cookbook solution. They don't want to be told this is what you have to do, and that's not what we tried here. We want to give them a conceptual understanding that they can integrate into their assessment and treatment every day. So by sharing this with them, you know, I think that goes a long way. Talk while you're doing this?
Yeah.
So Candy just did the first draft of we didn't get many. I think I got two. I've done a lot of work in patients who have lost sensation. For my dissertation, a patient got in touch with me from that, but I don't know how they. I guess it's just searching on the web. Yeah. I hope I didn't sound too.